Right. So just acknowledge if you can see the presentation.
Yes, John.
Yeah, we can.
All right. So appropriateness of group COVID-19 testing in low middle income countries. Yeah, so start with the definition of group testing from CDC. So pooling is sometimes referred to as pooled testing, or batch testing, meaning samples from several people and conducting one laboratory test on the combined pool of samples to detect the virus that causes the COVID-19 disease. So pooling should be used only in areas or situations where the number of positive test results is expected to be low. For example, low prevalence of SARS-CoV-2 infection. Pooling allows laboratory to test more samples with fewer testing materials. It could be used in scenarios like returning groups of workers to a workplace. So this strategy is being applied in countries like Rwanda and Ghana. These are the African countries that have adopted this technique. So the idea is to get more out of each COVID-19 test by skimming off a small amount of material from each person's sample, combining them into a single sample and running the tests. So if the sample is negative, then there's a good chance that all of the people who were polled in the sample are negative. But if the sample is positive, at least one of the people who are polled in a sample could be positive. And that is why if a poll comes out positive, that is when you go back to testing everyone who was in the pool. Now to arrive at that one person who was positive. That is the same thing that I've said. If the pool test is positive, each of the samples in the pool will need to be tested individually. Now, from the CDC guidelines, if you have a pool that has tested negative, so CDC recommends that no need of reporting to each and every person. And then they think that if these are positive tests in a sample, you should still not report the pooled positive results, because not everyone is positive in the sample. So you're supposed to perform diagnostic testing of each and every person. Yeah, so these are a few papers that are supporting this strategy. For example, testing can be done for H1N1 influenza virus without compromising the sensitivity of this. So 10 samples were ran with the CDC swine flu virus real-time PCR. The outcome was there was no loss of sensitivity out of the 10 samples. So out of the 10 samples, so that demonstrates that pooling strategy is feasible. It can increase capacity and conserve resources during surge testing, periods of enhanced influenza surveillance when the prevalence is low. So Richelle showed that a pool size of more than 20% are expected to reduce analytic sensitivity by 20%. So this is actually one of the challenges in pool testing. So the pool should not be very large. So CDC recommends that labs once to adopt pool testing should evaluate and validate the performance of an assay for a pooling strategy. So challenges I have mentioned, the larger if you look at the last bullet here, the larger the pool of specimens, the higher the likelihood of generating false negative results. So there should be a limit to the pool. So, and then laboratory cannot, if it cannot ensure the diagnostic integrity of an individual specimen, then this will compromise the results of the pool. For example, if the quality of the swab specimen is low, if the quality is low, so that might contribute a negative result to the sample, while that person could be the one who could have tested positive in a sample. So even if each individual specimen in a pool is adequate, the specimens in a pooled procedure are diluted, which could result in a low concentration of a viral genetic material below the limit of detection of a given test. So the prevalence of COVID-19 affects the efficiency of pooled testing. In general, the lower the disease prevalence, the lower the disease prevalence may enable a laboratory to use a larger optimal pool size, and the larger pool size would lead to a false negative or false positive results. A recent study in Nebraska Health Laboratory found that SARS-CoV-2 pool tests returned positive results when one positive sample was mixed with 4 negatives, and this was shown to reduce the number of tests needed by more than 50% in certain scenarios. Such when COVID-19 prevalence is 40% and below. Yeah. So, however, as the prevalence of COVID-19 increases, the cost savings of a pooling strategy decreases because more pool tests will return positive results, and those specimens will need to be retested individually. Implication for policy: the current infection rate in Kenya is actually, I think we are having a case, the infection rate of 0.03 the population. So, and below this level, pooling strategy can be applied. Then there's need to call the pool test for a country like Kenya because cost effectiveness. You get more. You make a decision on a group of people in one test, so that could be cost effective. So then the need to apply pool testing for low prevalence areas and groups. Labs should determine the prevalence based on a rolling average of the positivity rate of their own SARS-CoV-2 testing over the previous 10 days. And laboratories should use a standardized methodology to calculate factors in the sensitivity of the assay they are using, their cost of testing, to determine when the positivity rate is low enough to justify implementation of a strategy. So keep the pool size moderate, and the risk of false negative increases with the pool size. Yeah. So that is the end of the presentation on group testing. This is part of what Jawiria is doing, and I hope that has improved our understanding on what group testing entails. Yes, so I welcome any questions and contribution and suggestion on what maybe Jawiria will need to do or we need to do in that article. Yeah, and I think we haven't had any mention of a consideration of group testing in Kenya. So I think it's something that, yeah, maybe we should propose or we should just write about. Yeah. So welcome to just any comment and suggestions. Yeah, thank you.
Thank you for your presentation, John. Yeah, I don't know why the government has not yet considered pooled testing, because I think one of the things that you mentioned, the sensitivity of the test may be compromised in pooled testing, but the fact that more individuals are being tested, it's able to compensate for that, and that is what is needed in the current situation right now. And then I saw another paper I think I can share with you, where now they did for HIV pooled testing for children. I think it's not a very recent paper, but that has been done. It was done in Kenya. And in that paper, they found that, yes, pulse testing worked. It was efficient, and it had a high negative predictive value, which means that the people who came out negative on the test truly didn't have the disease, which I think is a bit contradictory to what you said, or maybe I didn't follow well there. Then it also had substantial cost savings. So yeah, it's been used for a virus. Yeah, so it's a good strategy. Those are my comments.
Yeah, Richelle, did you say they found a compromise on sensitivity?
Not in that paper. Just like generally, pulse testing may reduce sensitivity, but you're able to test more people, and you're able to reduce the cost. Like it's what can I explain it? That's one of the challenges in pooled testing. Yeah, some studies have shown that. I can also share that one, but that one is for a bacterial disease, not a viral disease.
So reduced sensitivity, but against reduced cost. Is that the compromise?
I think currently, if currently you would want to truly test a positive person. Like you don't want to give someone a false test when they are actually positive.
A false negative.
Yes, a false negative. So sensitivity is where you do not have the disease. That means you're disease negative, and you don't have the probability. Let me Google that shortly. Specificity.
Specificity, Richelle, is a probability of someone who doesn't have the disease and he tests negative.
Yeah, exactly. So I think sensitivity, we are more interested in specificity right now than sensitivity. Those are my 2 cents.
Specificity is identifying a true negative.
Yes.
So you want to identify those who do not have? Or do you want to identify those who have?
Those who have. Those who have.
So it's sensitivity.
Yes,
sensitivity is finding the positives.
Yeah, we want to increase our sensitivity, our true positive rate. Yeah, so okay, that would be contradictory to what I've said now. If
okay, revise what you have said so that we're sure.
No, in that, what I read was pooled testing has been known to reduce the sensitivity, but it's been compensated for by the number of individuals who are tested.
Yes, yeah, so it's effective.
Yes.
But you may miss somebody who has the disease.
Yes.
Yeah.
Yeah.
Yeah. So you don't use it in a place where the disease is prevalent.
Exactly.
Isn't it? So if it's a rare disease, then it's good because you'll test a lot of people.
Yeah.
And then you just have to repeat for a small group.
Yes.
So the other thing around pool testing is that you must get results back quickly.
Yeah, or it will be meaningless.
Or yes, if you have some positives in there, and you have to get the whole group together again. Okay. So, do we advise? Because it sounds to me that there are only a few counties where you can do this. But if we have low testing, can it be an entry point?
I think it can.
So that you if you have not been testing, you get into a whatever you test, and if you find a certain rate, then you stop and now do individual testing.
Yes.
Yes. Yes. Yeah.
Yeah. So something like the way they're doing the way they're doing companies or ministries and then shutting them down.
Yeah.
Would you pull test or not? Because it sounds to me like if you pull tests,
yeah, you would
in a place where people have been in close contact, the chances are you'll have to repeat for everybody. Yeah.
Yeah. Yeah.
Yes,
Yeah,
I think that
you
is
would.
where to apply.
So it won't work.
For the whole country.
No, not the whole country. I'm saying if you go into an organization, say like a company, and they've got 300 employees, would you pull test?
Yes, I think, sir, I think you can pull test. You can just come up with groups, optimal polls. For example, they should be, I've seen one study saying should not be more than 10 people. Yeah, the cost effectiveness comes in because once you test, for example, a pool of 10 people, and you have a positive, that is the only time you go back to test everyone in the 10 people to identify which people were actually positive. Yeah, and then when the 10 people are negative, you don't go ahead and administer individual tests to each and every person. So you'll have saved testing reagents and time. Yeah, I think you would pull test.
I have my doubts. Because
how so?
You see, if we have been in close contact with each other in an office, for example, and you batch test us, 10 of us, and you get a positive result out of that batch, it means now you repeat the test individually for every single person.
Yes.
So you now end up doing each test twice. Okay, to eliminate how many, because it could be, if you get a positive result, it could be we're all positive, 1 is positive, 9 are positive, 6 are positive. Yeah. So it seems to me that it works when you get people from, well, I don't know, if it works out to be negative, you're fine. But if it just goes back to the thing about widespread. If people have been behaving well and wearing their masks and doing all kinds of things, then you can do that batch testing. But if people have been misbehaving, then chances are there's somebody there with the thing.
Yeah.
At which point it is better to do individual testing.
So what you're saying?
Pardon?
It's too late for pool testing. What you're saying, Dr. Ayah, is that it's too late for pool testing.
Yes, I'm thinking that you then have to do, either you have to do some, you have to check whether people are eligible for testing as opposed to just testing people. Yeah.
Okay.
Yeah.
So then can you really say we have low prevalence of the disease? If we take the number of cases, the proportion of the people who have been infected in Kenya, and the population, the total population as the denominator, can we say we have a low prevalence of the disease in Kenya? Is that how we determine if we have low prevalence? Like the number of cases.
I would not apply this to Kenya. Kenya is
Yeah.
too big and the disease is varied, eh?
Mm-hmm.
So you're looking at outbreaks. So you have to decide whether there's where there's low transmission.
Mm.
Yes. So for example, when now we look at figures of Mombasa, you know, they've gone down.
Yeah.
Yeah. So is it that the epidemic is controlled in Mombasa? So that might be one place where you would go and you do, say, that kind of testing, right?
Yeah.
Yeah, but not somewhere where there's a lot of disease.
Yeah, like Nairobi. Yeah. Sure.
Yeah. Mm.
All right. Yeah. So I think so. That will be one. That will be a feasible recommendation. Yeah, to test counties where the infection, the number of COVID-19 cases are not as high as Nairobi and the neighboring counties, right?
Yeah. Yeah.
Yeah. Okay. And then with regard to the corporate testing or the companies testing the workers, is it? Do you still think it's not something that will be appropriate?
I think it wouldn't be, because I imagine that from what has been going on, chances are high that there'll be at least one person with the disease.
Mm.
So that would mean having to repeat the whole thing, unless perhaps you're going department by department and you batch here and you leave there.
Mm.
Mm.
Yeah.
So I think it's a fairly tricky thing.
Yeah. Maybe I've not looked at the details on how it has worked in Rwanda, or if whether that is a strategy they adopted since they reported the first case. But it appears that the government of Rwanda has controlled the pandemic because they haven't yet gone to the community transmission. Yeah, so maybe the timeliness even of the other issue would be now the timeliness of group testing. Yeah, maybe it's like what you're saying. It would be pointless to do it in a country with community transmission because the spread is in the community, and you don't have clusters. You have almost everywhere cases being reported from every part of the country and of the community. Yeah. Yeah.
Yes,
So
John.
so
Maybe
there's
John, maybe add to what you said. Rwanda succeeded because Rwanda fits in that criteria. The highest criteria of pool testing is mostly efficient when it's applied in a setting of low virus prevalence. And Rwanda has a low virus prevalence. Let's say in Africa, we might have Rwanda, Uganda, where they have a low virus prevalence, is when the pool testing can be applied, and those countries fit in that criteria. But from some of us as a country, it cannot work. And also it has advantages, yes, but for us to catch up in that pool testing is not easy, because after the community have the community transmission and catch up with pool testing, it cannot work. But in Rwanda, it works because they have a low virus prevalence. Thank you, John.
Yeah, thank you. Yeah, so perhaps if we had enough, if you see now the WHO has categorized Kenya as being in community transmission. So would you say that every county in Kenya is in community transmission? Is it is it accurate to say that now every county in Kenya is in community transmission? So from the ministry's reporting, we have been having a county reporting only 10 cases, another reporting 2 cases, another reporting 15, 100, Nairobi reporting now almost 10,000, 15,000. So is it appropriate to just batch the whole country as community transmission and assume we are in community transmission, and assume now all the strategies we are going to adopt are going to be uniform for community transmission? Dr. Ayah, is there a concern from a policy perspective? For example, batching a country as community transmission and then applying COVID-19 response measures equally in all the counties, like as if we are all in a community transmission. Yeah.
No, we can't, because
Can I? Oh, sorry.
Yeah, sorry, carry on, yeah.
Just go ahead, Richard. Or you want me to talk about that?
Yeah, please do, yeah.
No, I was saying we can't. Actually, you are reading my mind too. we can't, because of, as much as there's a community transmission, but you realize that we have different, I would call it prevalences, or incidences rather, of the virus across different counties. So Nairobi has the highest disease burden, and you cannot apply the same measures in Nairobi, in Turkana, for instance.
Yeah,
and, I'll give you an example of how we've been handling HIV. So we say that Kenya is a country, is in we are almost reaching epidemic control for HIV, for that matter, compared to other countries. Huh? But when you look at Kenya as a country for HIV, the prevalence in Siaya, for instance, based on the latest report, is about 18%. Compared to Nairobi, that's about 5.7%. So the measures that we put in Siaya, in as far as managing HIV, cannot be the same as the ones we put in Nairobi or Ghana, for that matter. So we have to understand the dynamics per county and then apply county-specific measures that move towards achieving the bigger country goal as it is. And that's why when the president had a meeting with the governor, the question was, how big is the burden in your county? And what are you doing about it as a county? What measures have you put in place? There's no way the Nairobi metropolis can have the same measure as Bungoma, whose disease burden is quite low. So I think it will be from that perspective, then you put different measures depending on how the disease is behaving, despite the fact that it's a community transmission at a global level. Yeah. I don't know whether Richard, you have anything you want to add?
No, that's exactly it. We have to move away from each of, well, counties is an administrative unit. So, yeah. But nevertheless, and that's how we've decided to do it. So it's one way of doing it. It's convenient. But then you have to look and see what are the characteristics of patients and how are they behaving and where is it coming from. So there's still counties where travelers are the issue, isn't it?
Yeah, for sure.
And the others where it's just, it's there. So, for example, and then even after that, I think you have to divide. You have to look at what is causing the transmission. At what point is it happening? So
yeah.
So it's not, people we've got the sort of studies from China, the West, and so on about what points it's happening. We haven't had characterized stories here properly. Like, for example, we know if you have if you're a grandparent and you have a party for your grandchild, Bishop Wanjiru style, or even my neighbor who unfortunately passed away, then you're in trouble. The ones of there have been a few cases where drivers have gotten infections And it's because they sit with their bosses in the car all day long. You know, those without air conditioning or whatever. So you're now looking into the detail rather than just saying, this is it. So the preparedness is part of it.
Yeah.
So now if you are doing that batch testing, you think about it that way. Where is the vulnerability? There was one in when Safaricom started doing the testing, they realized that it was the cleaners and so on, and it was the people who are privileged to be made T4. So they banned being made T4 and said, make your own T. Now, if that is true, then everywhere that should be the case. Should make your own T. So thanks for that. I agree.
Yeah. Actually, I agree with the sentiments by Dr. Barasa and Dr. Ayah. Yeah. So, and I think now that is the problem we are having, because we are treating counties the same. So we are not having a breakdown, for example, of the testing in each and every county, so as to get the point prevalence for the population. I think that would be more appropriate strategy in responding to COVID-19.
Actually, John, what you're saying is the debate they're having in Senate at the moment is exactly it. That's how we should be mirroring our COVID approach, to say counties are not the same. You can't all get the same amount of money.
Yeah, exactly. Yeah.
Okay, so if you can't get the same amount of money, why should you get the same amount of COVID?
Yeah.
Or COVID preparedness, for example, because you can't say all of you should have 200
300 beds. Yeah, exactly.
Yeah, I mean, and then your government will allocate you different amounts of money.
Yeah.
I mean, it's nonsense. Yeah.
Yeah. Yeah, that's exactly the point. Yeah. That's very interesting.
Yeah.
Okay. Yes, Dr. Barasa, you have something? Oh, sorry. Yeah, so that's quite interesting, and we will write about this and dig deeper into the group testing and its appropriateness for Kenyan counties. Yeah, so we could go ahead and say which counties would actually benefit more from group testing and which ones will not benefit more from group testing. Yeah, so in light of the limited testing capacity in Kenya, and I also think group testing will be a good strategy in reopening, because in reopening you must have your surveillance testing right, and the group testing has been recommended as one strategy in surveillance testing by the CDC. Yeah, so that would be very, very important. So in addition to this, Dr. we were to see how we can do a reopening index for Kenya, or propose, depending on the county COVID-19 status or indicators. So that will really guide the governors on what to do with regard to the containment and preparation, for example, for the surge or for the drop in the number of cases. Yeah. Dr.
Have any of you had a read of the original model?
Regional?
The scenarios that they talked about.
I haven't come across. Yeah, haven't come across them.
The one that they were planning all their whatever's on.
The original, it started in USA. USA is when the original started. The pulse testing. It was started. It was initially developed in 1943 by Robert Dorfman in America. It was an economist, and he was trying to use it, the test for sexually transmitted infections and malaria, as well as blood banking. Reason why he started that pulse testing.
Okay.
Good. Right. Any additional suggestion, comment? Okay.
Hi, everyone. Sorry, I have a question.
Okay.
I've been talking to a couple of people, and I find most people kind of they cite Rwanda and Uganda to have low prevalence of COVID, but I spoke to some of my relatives in Uganda, and it's not exactly that clear because they're not doing testing. And the information is not, you know, the government in Rwanda and Uganda are not exactly very free or fair, any of that stuff. So for this region, I don't think we should be comparing Kenya to Uganda or Rwanda, because it says that Rwanda is handling it well, but we don't have the data that's independent or tend to be independent. So I don't know if we should be comparing. From the conversation yesterday, should we be comparing ourselves to South Africa and Egypt? But also you find South Africa is homogeneous, just like Rwanda and Uganda. And as Dr. Ayah said yesterday, Egypt is in the Arab world. So for this region, I feel like we're very peculiar. We're not like Tanzania. We're not like Uganda. Tanzania has a different route. We took the route that we closed down the country, and we have some of these restrictions. I don't know what your views are. Thank you.
Yes,
Daniel, can you hear me?
Daniel, you are right. You are right. Reason why the country which is led by dictators, presidents, you cannot find the real data, because you have to report what the government wants you to report. You cannot report according to the accuracy or according to what you have. And the reason why in some of those countries you find that in the whole year they have 0% of maternal mortality, and you find that their statistic is depending on what the government wants them to report, because the government have according to they measure their success according to what they want, not according to the reality.
Sorry, guys, can you hear me? I think I don't know if I can hear me. I think I'm disconnected.
We can hear you.
Okay, I've lost connection. Richelle, can you hear me?
Yeah.
Dr. Ayah, can you hear me?
Yes, I can. Though now I can't, unless you're not saying anything.
Daniel, can you hear me?
Oh, yes, I
He's the
can
one
hear
who
you.
cannot hear.
Mhm.
So, Richelle.
Yes, Dr. Ayah.
You're the epidemiology person. Do you understand these how the spread?
In terms of?
The reproductive numbers and so on.
We were taught in passing. I kind of understand it.
How quickly did it pass when you were being taught?
No, I can refresh my memory and understand it.
So what is our current reproductive number?
Our current reproductive number, I don't know.
Yeah, they are not.
I don't know. Maybe someone can help me. The current reproductive number.
Yeah, I think it's worth. I'm just relating this to this discussion around the testing, eh?
Okay. Okay.
And whether whatever is widespread or not.
Okay.
So the R naught initially they talked about between 2 and 3. And then you're trying to get it down to under 1, and then the numbers fall, right?
Yes.
So our numbers are still rising. So clearly you can't tell because we're not doing mass testing. So you can't tell whether we're just finding what is there or whether the R naught is still above 1. But we'll assume it's above 1 for now. Okay, so that discussion around batch testing, is there anything around the reproductive number that would guide you to say, therefore, batch testing would work? So there was an issue about the prevalence, how widespread is the disease, but now we're talking also about how
infectious.
Yes. Yes.
Oh, okay. Yeah, that's something to look into. Pool testing, and if it can work with an infectious disease. Yeah, that's a different angle at looking at it.
So maybe we can discuss it a bit and refresh our minds around that, like exactly what is going on. Yeah.
Okay.
Just to keep that in mind. Okay.
Yeah. Sorry. Dr. Ayah, can you hear me now?
Yep, I can hear you.
Yeah, I think I lost connectivity for the last 2 or 3 minutes. I had to sign out and sign in again. Yeah, so maybe I missed a couple of points. Maybe I can catch up with Richelle or Mwema later and pull them down so that if there's some.
Yeah, I mean, I think it's just the angle of rate of spread. Eh? The R naught number is something else to think about when you think about this batch testing. Okay.
Okay.
Yeah.
To the end of the call today. Yeah, thank you very much.
Okay then. Guys, have a good evening.
Yeah, have a good evening too.
As we wait for the articles, yeah.
Okay.
Okay, bye-bye.
Bye.
Okay, bye-bye.
Good night.